So good evening, everybody. I'm Edwige Poncel. I'm the Vice President of Dystonia Europe and the President of the Dystonia French organization Amadys. Tonight, it is the 6th webinar of the Dystonia Europe series, and it is organized tonight by Amadys and Dystonia Europe together. We will talk about care for dystonia in times of COVID-19, about management strategies, vaccination, and more. I'm glad to introduce two French specialists, Professor Marie Vidailhet from the Pitié-Salpetriere Hospital in Paris. She's a professor of neurology, member of the Dystonia Europe Scientific Committee, and President of Honor of Amadys Scientific Committee, and Dr. Christophe Vial, neurologist in Lyon, who is the actual president of Amadys Scientific Committee. Tonight, we will hear the neurologist's vision on dystonia and pandemic. Our dystonia specialists are not COVID epidemiology oriented and don't know, like all of us, how epidemic will rise, but they do know us very well, dystonia patients, and will answer our common questions or give us their advices. You have the possibility to write your questions in the chat button on the bottom of your screen, in English or in French if needed. And I will check it and Dr. Vial will do it so. I wish you all a good session and please, Dr. Vial, if you want to say a word, you're welcome.
Thank you, Edwige. Hello, everyone. I'm Dr. Christophe Vial, Chairman of the Scientific Committee of Amadys for 2 years, following Professor Marie Vidailhet. I'm neurologist at the Lyon Hospital, Neurological Hospital, and responsible for the botulinum toxin injection consultation for almost 30 years. I recently received my 2 injection for the COVID vaccine. And as you can see, I'm always in good health. For this webinar, in agreement with Dystonia Europe, as Amadys is at the origin of the webinar, I will ask the question in French, and Professor Marie Vidailhet will reformulate them in English, so as not to lose any information. I would also myself to be naive to ask the question which that were not asked. So don't forget to chat for this webinar. Marie?
Thank you so much for this introduction. I think everything has been said. My name is Marie Vidailhet. I'm a neurologist in Paris, France, in Salpetriere Hospital, taking care of persons with dystonia, botulinum toxin, deep brain stimulation, and so on. And having within the Paris Brain Institute, the research center, a team called that is together with Stéphane Lerici, neuroimaging, and a group of very enthusiastic people to work on dystonia and also in tremor and Parkinson's disease. And I'm very proud and very honored to be with you tonight. And I thank very much Dystonia Europe for inviting me tonight. And I'm very proud to share the screen with friends and colleagues and with you. The topic, as Edwige said, is dystonia in COVID time. Well, it was the idea to, it was like love of dystonia during that COVID time. And as you see, the small picture shows that now we have gloves to touch each other and transmit a lot of life to one another. So what you see on one side is the Salpetriere Hospital, which is 18th century hospital, and on the other side we see the research center which is on the other side of the hospital, and researchers, doctors, and patients can go back and forth from that one place to the other. So today we have a short presentation, but the main objective is to have a discussion together. I will try my best to answer your question. I don't know the answers to all questions, and I don't know everything about COVID because nobody knows everything about COVID, but we will try our best. And also you will bring information that may be useful for our operation in France or in other countries in Europe. And please share briefly this observation and information. It will be very, very useful for all of us. So now we had 5 objectives, and this 5 objective is, my screen is not frozen. It looks like it is. No, these 5 objectives are here. That's the same as anybody in the population, get informed about COVID-19. One question is dystonia a manifestation of COVID-19? That is, are they dystonia related to complication of COVID-19? And we answer that question, at least with what we know about it now. Vulnerability factors, who are the people who are at risk of getting a bad COVID-19? And are dystonia people more at risk, more vulnerable, or are they like anybody else? And there are a lot of questions everywhere about vaccination. So can people with dystonia be vaccinated? Well, as we saw that Dr. Vial is vaccinated and is happy and healthy, and I'm healthy and happy, and I have been vaccinated too, and it was okay. I didn't have adverse effects, and that's good to know. One of the questions which is very important is how we deal with dystonia in this time. Is it worse, or is it not worse, or even better for some aspects? And that will be the opening of the discussion. So get informed about the COVID-19. What do we say? What do we know? We have, of course, and it was on the first slide, COVID-19 and protection. Are these protection efficient? Well, if you take the protections, of course, none of these protection or intervention are afforded complete protection from infection. So if you take only physical distancing or only mask, is not enough. So you have to combine a few of them. Physical distancing. It's very interesting because depending on countries, and we will see that later, the distance is not the same. And it's kind of gradient from north to south. So it's 1 meter or more, which is a minimal distance, and there is a lower transmission compared to a distance of less than 1 meter. So 1 meter is one of the standards, and protection is increased, of course, if it's a larger distance, and distance of 2 meters may be more effective, of course, because when you speak or sing or whatever, or even eat together, you spread droplets, and in these droplets you may have virus. So if you are far away, of course, they cannot travel to the next person. The mask, we have the face mask, which is a surgical mask, and it reduces the risk of infection, of any infection, by the way, because there are very few flu in France, at least at the moment. There are very few people having flu or even colds because they wear a face mask, and that protects people from infections that travel through droplets. So it's something which is non-specific, but that may help very much people, and you don't need an FFP2 mask, except if you were very close to people like dentists, or if you are ophthalmologist, because you are very close to people when you examine them. But for everybody in everyday life, the usual surgical mask, or the mask that has been sold and it's out of fabric, may be enough. So that's something which is important. Present. Yeah, but of course the main question is vaccines. Well, we struggle to get vaccines because well, there is a difficulty having enough vaccines for everybody. What is the principle of vaccine? Well, it's the same for COVID-19 as for any other disease. The aim is to expose the body to an antigen, which is a virus, for example, that won't cause the virus. So you get something which is not harmful, but it will provoke an immune response. And that immune response will block or kill the virus if the person becomes infected. So it's a real protection for yourself and, by extension, a protection to the people around you. So there are several vaccines now on the floor. One which is a bit more original, I mean, it's a new thing, not quite new because I will tell you more about that. It is a nucleic acid, the RNA vaccine, which is a Pfizer BioNTech, and also the Moderna one. This one is not completely brand new in terms of technology, because, for example, it was also an RNA vaccine for Ebola, for example. So they worked already on that kind of vaccine, and they know about it, the researchers and the doctors. We will see why it's very strong, because it's protected for wild variants, one which is the most frequent, but one is getting back to being very frequent, which is a British one, and the protection is not as good for the British, and even not as good at all for the South Africans. So that's important to have also protection like mask and social or physical distancing. There is the other one, which is a viral vector. That's something which is very classical. That's the usual vaccine, like for flu, and that's the AstraZeneca, which is still very good because it protects up to 70% for wild variants, and it's not very clear if it's as good for British or South African variant. And there are also something a bit different, which is a protein-based vaccine, which is just little pieces of the virus that are injected. And there is another thing that protects you, but we cannot reach that now, which is a herd immunity. What is herd immunity? That's the immunity of the population. So if many people are protected and don't get sick, of course, they will spread less virus, and you have less risk to get in contact with infected people or sick people, and less risk to have COVID-19. So that is far for obtained at the moment. So COVID and protection and social distancing, I'll go back to that because that's very important. You see the mask, the gel, and the distance. And it's really interesting, I'll show you, because in Germany, Netherlands, and Belgium, northern country, is 1.5, and in the southern country, France and Italy, it's only 1 meter. Well, we are using the south of Europe to be closer. 1 meter is a huge distance to all of us in southern Europe. So 1 meter is already something that is a feeling of being really, really far away from your friends. So we have these different vaccines. This paper, these small cartoons are taken from Nature, which is one of the most prestigious scientific journals at the moment. And they had these cartoons to explain to scientists who are not specialized in virus or epidemiology or even infectiology what is a vaccine for COVID-19, because it's interesting for anybody in the population. So we will concentrate on the blue, green, and red one. And the one we have at the moment on the blue and green, sorry. So the one that frighten the people, because they say, oh, that's too new and we are afraid to have something, we are not guinea pig, we don't want to be vaccinated with something which we don't know about, and we want to have more time to think about it. That was a nucleic acid vaccine. As I told you, they are not so new because they were already used in other disease. So what it is? It's very safe, by the way, because there is no virus in you. In the virus, there is a small piece of nucleic acid, which is the RNA. So you take that piece which is only a very partial part of the gene of the virus, not the whole part. So you cannot have the gene of the virus per se into your own genome, and you inject that into the muscle. And in the muscle, you have cells, and these cells take this DNA, this RNA, sorry, and they copy it, as they do for any RNA in your body. They copy it and they make a fake virus. So they make something which is a viral protein. They make a fake virus because it's not infectious and it's not even a virus. It's just a viral protein. They do the job, copying RNA, making protein. This protein has the proper protein of the virus. So it's a fake virus, but not in the shape of a virus. And when they go into the immune cells say, oh, that's really bad. We don't want that one. And they kill them. And so that's a really strong protection and also a very quick one because this copy of RNA is very fast. So you have an immune response, which is very important and also very fast. And you have 2 injections separated by 4 to 6 weeks. And that's why you have this high level of protection with these ones. The drawback of this vaccine, as you may know, is that they are very fragile and you have to keep them in -80, which is not all the fridge in your house or even in the doctor's house. So that's why it's a bit difficult to have them on a large scale. So we jump to the one which is easy to carry to the pharmacist or to the doctors or to the hospital, which is a green one. And that's a viral vector vaccine, which is very classical. That's a classical one. So you take again a piece of the virus, of the COVID-19 virus, and you put that in a virus which is harmless, something that will not do you anything. It's inactivated in a way. So you have a virus shape with the piece of COVID-19, and in the body, you get something that looks like a virus. So the body is a bit suspicious and it says, does it not look like a virus, that one? And they say, yeah, it does. Wow, kill, kill, kill. And they kill it. Okay, so, but it takes more time. And that one, it takes a little bit more time, but it's very, very also effective. And this kind of virus is, this kind of vaccine is the AstraZeneca. And it's very effective too, with a protection up to 70%. But you have to have 2 injections again. And usually we have them, at least in France, 9 weeks to 12 weeks after the first injection. We get back later on the adverse effect, if so, to this vaccine. And the last one, which is not yet on the market, is a protein-based vaccine. So you remember the virus is called coronavirus because it has this kind of crown on its head. And this crown is like with small spikes. And these spikes are the ones which are really obnoxious because that's the one that will trigger not only the absorption of the virus by the body, but also a little bit of the reaction. So you take not the virus per se, but you take this small piece of crown. And when the body sees this thing, they say, oh no, it looks like a virus. It's not a virus, but it's not a duck, but it quacks like a duck, so it may be a duck. So it's not a duck, but it's a virus, or it looks like a virus. And also, again, the immune cells take that and say, okay, we don't want that thing in our body, and they kill. So you see that it's very subtle, but also very simple if you have a picture to understand that. And that's the strength of this journal, the scientific journal, which is Nature. So that was the animation, but we have to go further. And now, if we want to know more about that, well, not every doctor, even these people on the panel, know about everything about the COVID-19. So my colleagues of mine, scientists from a different, very prestigious research center, so that they had to contribute to the knowledge, and they made a free, simple, accessible, scientific, practical, and updated website. And that I wrote the website, so you can go into it. It's in 9 languages, so you will find the one that you are talking. And these people thought they had to be mobilized against disinformation because there is a lot of fake news everywhere going on and frightening the people and preventing them to do what's right for them. And they have a lot of small dots, and you can click on one of each, and you have plenty of things from understanding, protecting, vaccination, adverse effect, and everything. So I just spotted two of them. Propagation, how to use adios corona. Well, propagation, there is a lot of talk on the TV, radio, and so on propagation. And we talk a lot about R0. What is R0? R0 is the baseline reproductive number of initial transmission rate of the coronavirus. Wow, that's long. Well, it means that if I get the virus and I spread it, and the R and the R number is R3, I will spread that virus to 3 people. So I will spread that virus to 3 people. So it makes something which is more or less exponential, and it makes a big number of people. So the idea is to stop this transmission from one person to the other and to decrease our figure. And if the R0 is less than 1, it means that the spreading had been stopped. Well, we are far from that at the moment. So the second thing could be the vaccine, and we will get back to that. So we have to the second objective. Is dystonia a manifestation of COVID-19? In other words, in the neurological department, intensive care units, and infectious disease departments, do we find people who were safe and having nothing before they had COVID-19 that developed afterwards, after the infection, dystonia? That's a very good question. Are there dystonia related to COVID-19 infections? And the short answer is no. So this work has been done by Cécile Delors, who has collected all the COVID-19 neurological manifestation in more or less in France with the people who wanted to participate in this survey. And we have a large number of neurological manifestation, from encephalopathy, stroke, that's all well known, peripheral neuropathy, and absolutely no dystonia reported to date. Some paper mentioned that there are people that have COVID-19 and very severe encephalopathy, may have abnormal movement, but it's part of a huge group of neurological symptoms, and it's not the one that lasts, because when we see people who recovered COVID-19, we found a little bit of tremor or something like that, but we didn't find dystonia, and I believe that we will not. So the next third objective is the vulnerability factors. So are the dystonia person more vulnerable? And well, the short answer is no, and we see what is the long answer. So the short answer is these factors are the ones that are published, said in the TV, media, and so on, which is age. The elderly people are more fragile and they get more sick than the young people. So people over 65 are 50% more likely to be infected and to have symptoms that are more severe. And the second point, which is important, is comorbidity, and that's why people said that these people with comorbidity are priority people to get vaccinated. And what are they? That the usual comorbidities: diabetes, severe hypertension, obesity. It's a huge obesity with EMC, I can't remember exactly how we call that, over 30. Cardiovascular or respiratory problems, severe asthma, bronchitis, and so on. Kidney failure, and of course, immune deficiency, including hematology disorders or even cancer. So these ones are fragile people, and they will more likely develop serious symptoms. And of course, the ones who are more at risk are the people who are exposed to a lot of people, like caregivers in contact of elderly people or in hospital, people in contact with fragile people who are not protected, like with homeless people, migrant people, sometimes people with severe psychiatric disorders and don't understand what to do. So these ones are in contact with people who are already at risk. And of course, it increases the risk for them to be contaminated. So that's the one. I will not comment the picture on clinical feature because that's a natural evolution of somebody that may be infected. There is up to 7 days of time, days without symptoms, and then people develop a little bit of pulmonary symptoms most of the time, and then have breathing difficulties. Sometimes they're not very much aware that they have breathing difficulties, but when we discuss with them, you see that in contrast with me, that they keep talking and talking without breathing, they cannot say a sentence with more than 5 words in a row, and they have also a little bit restless without being too aware of it, and can evolve to something worse or not. So dystonia is not a vulnerability factor until there are additional risk factors. The risk factor, we saw them already, and there are also risk factors like respiratory problems in dystonia. And when do we have respiratory problems? When there are severe thoracic deformities, like a bad scoliosis or bending of the trunk or things like that. You cannot breathe perfectly well, and you have a restricted volume of your thoracic cage. So these people, of course, are at risk, but it's not dystonia per se. It's a consequence of dystonia that makes them breathe with more difficulties. And it's not really clear if people with laryngeal dystonia are more at risk. They have difficulties breathing, but they can breathe normally, and their oxygen in the blood is normal. Despite that, well, they feel that they are not too well, and by the time being, they are not considered like at risk, but it's a bit more difficult to take care of them because of these breathing and talking difficulties. So dystonia, again, is not really a vulnerability factor, except if there are additional symptoms or risk factors. So vaccination, we went through the vaccination before, and I will not spend too much time on that slide, but the vaccine recommendations are a bit different from one country to the other. Although the people from Europe, the health care system from Europe, went together and had common recommendation to avoid that there were disparities among people, and people get a lot of vaccine and others no vaccine, a lot of protection or no protection. So you have a few websites on different countries that you can browse if needed. So there are people who say, I don't want to be vaccinated because I'm very afraid of adverse effects. Well, maybe we make a big fuss about it. And there is no reason we should make a big fuss about it, because people are not so fussy when they have a vaccination for flu, for example. And flu is also a vaccine that are more or less the same technique like some of the vaccine with COVID-19. So what's the adverse effect or reaction to COVID-19 injection? By the way, they are very rare, and very rare, less than 10% are very intense. Most of them are mild. And that's a discomfort at the injection site, but you can rub a little bit gently the injection site to make sure that it doesn't hurt too much. Sometimes, and I had that, you had fatigue the day after or a few hours after. You may have a moderate fever and you take paracetamol, and sometimes people like flu-like symptoms. There is an exception of allergic reaction, and there is no real contraindication of people who are allergic to cat fur or to flowers or things like that. And the younger you are, the more your immune system is reactive. So you may have more reaction if you are young than if you are a little bit older, because your immune system is less reactive, but is reactive enough to protect you and to get your vaccine active. So I think that it's important to discuss the adverse effect with people before we vaccine them. And I was volunteer to do the vaccination, and I will do that next Saturday, so in two days' time. So I explain to the patients and to the subjects that they have possibly these reactions, and they stay at home and rest until it goes away. So next, that's a very important point, and that will be the one open to discussion. How is dystonia, care, and everyday life in this time? Is it worse or not? Or depending on the situation, depending on the people, and depending also of the character of the persons. So we start with the gray zone. When people are not happy, they are a bit anxious. I think that like any other person, except that people with dystonia feel that they are a bit special, and they have a fear of contamination, and they are also maybe a fear of being in social isolation because they don't get as much attention as needed, either by their friends and family or by the medical and medical system or health system. We don't have to say, oh, you are anxious, and that's, we judge on that. We judge these people saying, oh, that's not good to be anxious. You shouldn't. That's not a good reaction, at least in my opinion. All fears are legitimate. Some people fear spiders, others they fear I don't know, tigers. Well, all fears are legitimate. We cannot judge that. And there is no value judgment that should be made on the expression of these fears. You accept them, and then you try to be as neutral as possible in the discussion to explain the pros and cons of the vaccination, and also the fact that there is always a solution to that. So not only in the dystonia population, but also in any other disease, and also in the general population, there is a risk spike, there is rise of depression and anxiety. And I must admit that the TV, the radio, the social media, the fake news, I mean, we are overwhelmed by all this information. Everybody has an opinion but me, and everybody has a different opinion, which is worse. So there is a fear of this communication, which is over-communication, and we cannot make up our mind on what is right and what is wrong. So that's the first fear of information, fear of dying, fear of the vaccine, fear of the disease, and all of them are legitimate, but we have to think of it and try to find good reason to be a bit reassured. The other gray zone is definitely because of physical isolation that became a social isolation, which is a lot worse, have altered social interactions. And it's really something that is a burden on everybody, but it's worse on people who have already sometimes difficulties talking to people, being shy, a bit withdrawn. And if you have a decreased interaction, it's really something that may be bad or not. Bad because the mask make it difficult to identify facial emotion, so it's difficult to communicate to people. But I had some patient who has mesh syndrome, and they said, well, that's good because now with the mask, they don't see my movements. And so I can communicate with people without seeing them watching me because I have abnormal movements. So the mask may be a facial protection against the scrutiny of the people who are in front of you. But sometimes people have difficulty talking. It's difficult to understand what they say because of dystonia. And the mask, on top of that, by hiding the mouth, transforms the voice, and there is a loss of intelligibility, and the communication may be broken. There are also what happens in dystonia, which is not only a motor disorder, but there are non-motor symptoms like anxiety or depression or self-deprecation. And of course, because you are isolated and a bit withdrawn, that may get worse because you are anxious because of the disease, because of the social interaction, and because of the social interaction in a very bizarre environment where everybody is a bit anxious too. there is no support. And the very last thing is because people are isolated, they may have less motor control, or because they have a little bit of fever, or they're a bit tired or a bit anxious, they may be an outburst of their usual movements. On the gait abnormalities of the abnormal movements, more shaking of the hand, more shaking of the limbs, bending, things like that. And on top of that, because of this isolation, there is less or no or little access to the usual care, which is physiotherapy, speech therapy. People are a bit afraid to go to the hospital, to their doctors, and there may also be restricted access to care because the doctors and nurses are busy with the COVID patients. This fear of going to the botulinum toxin clinic, we had the topic on that with Amadys, and we shouldn't because we pay attention. And I say the hospital is a lot safer than the supermarket, I must say. So the fear of contamination is more of a contamination in public transportation, much more than the outpatient clinic, because we are really with alcohol and protection and mask, and we try our best to keep people safe. When people are at home and they work, they have this telework. I don't know if the word is proper. So they have less exercise. They cannot go out and walk. Being in your place is not in your office, so you don't have the proper chair. You may have not a table which is fit for working. So there is no ergonomic postures. And of course, because you are in your house, I mean, the office is has invaded your house. So you have increased workload and long hours. And again, we get back to the non-motor symptoms, anxiety and depression that make it worse because, of course, because your symptoms are more fluid, you feel more anxious about that. So care, that's the last point. What about the care of dystonia, which is made in the head of the people with dystonia, not high priority for hospital. Say, okay, they take care with COVID, they are taking care of the people with cancer and so on. So we will be the last person, the last man or the small man on the totem pole, like say the US people. But there is no interruption of hospital and outpatient clinic care. In contrast with what happened in the first 3 months, we had the instruction to stop any outpatient clinic, go to teleconsultation, and take care of the people in intensive care unit or in infectious disease departments. But now we have the authorization, and we are happy to do so because we missed you. Definitely, we are happy to have people in the outpatient clinic and to treat them, and we do our best to do so. Because of the safety measure, we maintain the botulinum toxin clinics, we maintain the follow-up of DBS patients. We now even operate some of the DBS patients and pay attention to keep them safe. And of course, we have a few teleconsultations, but nothing is better than personal contact. And now we also have physiotherapists and speech therapists who developed teleconsultation. Well, it's not as good as being together, but at least it helps. And it may be something that goes together with the personal care, and you can alternate from one to the other. So at least in our vision, the vision we have in France and talking to people from different countries, we are in a different era in this COVID era, which is not the first outburst where everything was frozen, but now we try to adapt and to make sure that people don't lose the possibility to have the proper care in the proper time for their own disorder, because they deserve that as much as people who are in a more severe condition. And I'll be happy to share with you what's your impression about that. And thank you for your attention. I'm ready to answer questions when I know the answer.
Thank you very much, Marie, for this very clear presentation. We don't have so many questions because you have treated all the problem, all the aspects. I want to congratulate the site Adios Corona. It's a very interesting site because all the answers are clear and very scientific. it's different from all the fake news we can heard at the TV or the radio. So we can promote this site Adios Corona. Now I speak in French. J'ai quelques questions quand même sur la toxine botulinique. Est-ce que tu conseilles un délai entre l'injection de la toxine et une éventuelle vaccination? Est-ce que la toxine est à risque pour le coronavirus ou à risque pour la vaccination?
Yeah, that's a very important question, and thank you for asking them. So I will just summarize them. One of them is if you get botulinum toxin injection, should we avoid to have the vaccine in the next few days or before or after this botulinum toxin injection? And well, I asked the infectiologist, and they say we don't see why we should have a particular interval between the two. There are people who get chemotherapy, for example. That was the interruption between botulinum toxin injection and the vaccination. So the idea was that the infectiologist says that there is no reason why there is something that they would have a special attention and a special delay between one and the other. The mechanisms are very different. Botulinum toxin is a protein, but the immunization against this protein is very, very rare and very, very low. And the immunization for the vaccine is high. And there is no interaction between the two. So if, for example, it's very hard to get an appointment for the vaccination. So if you get your botulinum toxin injection on Monday and you have an appointment for the next week, please don't cancel and get your injection with the vaccine against coronavirus. Yes, that's right. And there should not be something special about it. So that's the very first point. And the second point,
if we have to inject with a delay.
Yeah, the delay. So there's no need for a delay between the two. That's really something. That was the short answer. I'm from the UK. My eye injection, what to say? I got something done in Oxford and we are performed in January. Unfortunately, my face and neck injection were done in London have been postponed. Okay. Well, so it says that increase of the interval between injections. And especially when your center is overloaded with work, well, it may happen because we have also to catch up on the injection that were not performed in the very first part of the COVID era. So not only we have the people who come on regular interval, but we have also the people who didn't get injection. So it's a bit complicated to juggle with these appointments. And there is no, of course, it's very uncomfortable to have a longer interval, but we do our best. And of course, you are less comfortable and we are less happy to make you uncomfortable, but well, it's a hard time for everybody and a hard time for you, but I can tell you it's also a hard time for us. And then we have benzodiazepine for those who are really improved or by benzodiazepine, at least a little bit.
Okay.
That was the answer to other questions?
Yes. Some other question about dystonia and COVID. Est-ce que quand on a une dystonie, on peut faire une forme plus sévère de COVID? Est-ce qu'on a un risque plus important de faire une forme chronique? Et est-ce que on peut développer un tremblement qu'on n'a pas à la suite d'un COVID?
Oh, they are very good questions. I will take the last one first, which is say we get a COVID-19 and get infected and had an infection with that, and we didn't have tremor beforehand. Say, for example, we had a head neck dystonia and no tremor. And can we develop tremor as a kind of post-effect of COVID infection? Well, I must say that at the moment we haven't observed something like that. And by the way, person who had neck dystonia may sometime over time develop postural tremor of the hand as part of the dystonia manifestation. That's the other part of the dystonia symptoms. I mentioned the slides that we see tremor in some people who got coronavirus. Usually we see that in patients who had spent some time in intensive care unit with very severe coronavirus, and this tremor is a bit complex because it may be a little bit of tremor as part of the last symptoms of coronavirus, but it can be also a tremor related to weakness because, of course, these people lose a lot of weight and a lot of muscle, so they shake because they are a bit wobbling on their head, on their feet, and it could be also because as part of the coronavirus they get nerve lesions, and nerve lesions may neuropathy, and nerve lesions may have as a consequence a tremor. So this tremor is really multiple origin, and there is very many other causes than dystonia as a tremor. So the short answer is tremor in dystonia related to to late effects of coronavirus. To date, the answer is no. The second question is, if I have dystonia and get infected, would I have a worse disease as compared to somebody who doesn't have dystonia and got infected by coronavirus? And the short answer to date is probably not. I say probably because dystonia is rare and we don't have plenty of people with dystonia who got coronavirus, but probably not because we really now know well the factors of, so to speak, bad evolution, and that's really age, obesity, respiratory disorders, diabetes, renal failure. So that's the one, and hypertension. But it's being overweight with hypertension and being, over 70. They are the ones who make the bad people bad coronavirus in intensive care unit. And I've been in intensive care unit as a go-between the ICU and the families. I'm not able to take care of patients in ICU. And the only one who were really in bad condition had this risk factor, but not dystonia.
And what about DBS people? People with DBS, sorry. Is there a risk to develop problem with their dystonia after coronavirus infection?
Well, that's a very good question. People with deep brain stimulation and people who had quite severe dystonia, so it was already very hard to control. And it's not the coronavirus that we may, theoretically, people with DBS and dystonia worse. But what makes the people worse when they recover from a very severe COVID-19 is the fact that they lose weight and they have no muscle, so they are very weak. So if they had already difficulties walking, it's getting worse because it gets worse because of this weakness, of this loss of weight, with this loss of muscles, with this neuropathy, with a loss of sense of position of their feet on the floor and things like that. So that's a consequence of the severe aggression of the body by the virus and not of the disease per se. Of course, if you are not in a good condition before, you are in a worse condition after, and then it takes time before you recover. That answers the questions. The people with DBS also may have a truncal dystonia with restriction in respiration, and And that probably, but it's only my opinion, that one advice to seek for vaccination, because I consider that I have a condition with already very hard to deal with for themselves and for us. So I say, okay, but they are not considered like priority. I have to make a certificate to say you should be vaccinated.
Okay, Marie, do you know if there is a specific register for dystonia and COVID? Because we know that there is no dystonia after COVID, but we don't know if the large population of patients with dystonia will have, after COVID, some modification of the symptoms, by example.
Mm.
So
that's a very important question. The short answer is that we don't know if they will have a change of dystonia after COVID. There are registries, and these registries are for all, first of all, for all manifestation of COVID-19, and you cannot open a scientific paper without having 10 papers on COVID-19. So they have a kind of survey of every manifestation of COVID-19, and you have special registries which are for any neurological manifestation. So anything that is observed after COVID-19, whether or not these people are beforehand neurological disorders, could be Parkinson's disease, MS, dystonia, you name it. There is this kind of follow-up and this kind of registry. There is one in France. There is one in Europe, which is created by European Academy of Neurology with all the countries. There is one in US. So it's so important to know about it, that there are registries everywhere, and we will know the answer in a few months' time, or even a bit more. Probably next year we have all the data.
Okay. One specific question about Johnson & Johnson vaccine. We don't speak about that because I know there is only one injection, and it's a vector viral. You speak about that. It's the same than AstraZeneca, I think.
Yeah, it's the same as AstraZeneca. By the way, well, we don't have it in France, so we have no experience about it. But it's the same as AstraZeneca. So, and in the papers, it says that it's the same amount of protection and so on. So, what you can read about AstraZeneca will be true for the Johnson & Johnson, I think. But, well, it's just by reading that I know that. There is one question that I see. There is somebody from another country in Europe, which is not France. And this person say, can I come to France to get my botulinum toxin injection? And I'm sorry to disappoint you, but I think at the moment, I'm not sure that people can travel easily from one place to the other. I wouldn't say a no answer, but it's probably not as easy as it was a few months / 1 year before. So I would not encourage you to make all that effort physically to fund transportation and also financially, because probably there are very few trains or planes going, and discuss with your doctors that may help you to get what's needed.
Une question naïve, provocante. Si quelqu'un a une forme génétique de dystonie, est-ce qu'on peut totalement le rassurer sur le fait que quand on parle de vaccin mRNA, il n'y a aucun impact sur le matériel génétique et donc aucun impact sur le côté génétique de sa dystonie?
Very good question. I think that's a lot. That's one thing that was one of the fear and more or less fake news about this mRNA vaccine, because the mRNA is something that never goes into, at least that in my knowledge, into the nucleus where the DNA is. The RNA is very fragile and it's just a little piece. As soon as it is here, as it has to be copied and transformed in DNA, but not copied and transformed into protein. It's like a kind of blueprint of the protein. So you have the ribosome that takes over the RNA and turns that into a protein. So it's a very fast thing. So as soon as the RNA here, the ribosome that makes its duty, they stick together because the RNA has to be transmuted into a protein. So the risk is minimum or known or null to jump into the DNA of the nucleus, which is far, far away. It's as if you were in Sicily and we want to go to Denmark. Takes some time, except with a plane, of course.
I have no more question, but can you confirm that if patients with dystonia have some anxious question that has been treated with this webinar, can you incite them to do vaccination?
Yeah, I think I would discuss that way. I think vaccination is good for you. I also think that if you really want to have vaccination because you're anxious about the disease, you have to talk with your doctor and obtain this exception certificate saying that he thinks that you need that vaccine because you're not in the at-risk people. But sometimes we can have people that we think that deserve having it. Deserve is not the right word, but should have it. Say, for example, generalized dystonia with deep brain stimulation, I made certificate, but that's my opinion and that's your opinion. If people are a bit anxious, I think that the disease is a lot worse than any adverse effect of any vaccination. And I may say so because it's really a bad disease when it is bad. And I would recommend that people think hard about it. They go to this website, Adios Corona, and have proper information, which is absolutely neutral and dependent by scientific. There are people from Pasteur, there are people from basic science research, there are people from different reasons. So they have no interest to sell anything, to sell the vaccine, to sell the idea of the vaccine. They just want to give you the more neutral information so that you can read through that and you will see that the benefit, even if it's not 100% because it's not 100% efficient, is far, far better as compared to having a disease, even if it is just a mild to moderate one. Because I had friends my age or even younger who got a disease, not in intensive care unit, but just before, just ready to go across that door and not going across, luckily, they were not well. So if you can protect yourself and protect your friends and protect your family, please do. We like you.
Thank you. I think it's a good conclusion.
I think so. There is nothing more to say. So I will do the conclusion that way. So thanks a lot, Professor and Professor Vidailhet and Dr. Vial for your time, your work, and your kindness. It's so much appreciated, and how you talk to patients, how you explain, so that we can all understand easily, and for your support. And yeah, thanks a lot.
Thanks, Edwidge.
Thank you, Edwidge, also for all the energy you put into that, because it doesn't, you are always very shy about what you do, but I would say that, well, you are really behind the scene, but you should be on the scene because of everything you've done. And Christophe, the special thanks publicly, because we had a call just one evening, just before 6, which is the time when they shut down all the shops. I was ready to go and buy myself a cake. And we sat together on the phone, me on my car and Christophe in his house. And he said, well, I will go through all the literature and everything that I can find to help you preparing that. And yesterday night, late at night, going into the early morning, thanks to you, I had 4 hours sleep instead of having red the eyes night. So, and that was tremendously useful and also very important and very high priority information, high quality. So thank you very much for your help and your support.
Thank you, Mary.
Thanks to you both. Take care.
Yeah.
You too. Bye-bye. Bye-bye,
Bye.
everybody. Thanks for attending.
Good evening. Enjoy it.
Yes.